Thank you. Every time I hear somebody talk about, I didn't write that. John wrote that or somebody else did. I don't recognize that person when they describe him. I'm a statistician and a biologist and a business consultant. But thank you very much for having me here today. We're happy to speak with you about the work we've done. Everything I'm going to talk to you about today, we did in conjunction with PinnacleHealth, which is a health system out of Harrisburg. So you see their logo on the slide, and you'll see them throughout. But we like to acknowledge the folks we work with, and we will try to give you I try to choose topics and to emphasize points of learning and best practices in the development and implementation of these types of models. I'm not going to talk a lot about tools today. I'm not going to talk about technologies. If you have questions like that, I'm happy to bring them up. I tried to stay away from those topics a little bit. I really appreciate having the audience here present and on the web. So let's get started. If I can figure out how to advance the slides. Let's try that. There we go. All right, just a few words about PinnacleHealth as a health system. They are a growing concern in central Pennsylvania. They had 2 hospitals for a number of years. They recently added a 3rd for the West Shore facility. They're approaching 1,000 beds in those 3 hospitals, and they are a busy healthcare provider in central Pennsylvania. Just a couple more words about PinnacleHealth. They are, like a lot of health systems that we've encountered and worked with, they recently engaged in an ACO. They're going through a merger with Hershey Medical. They are growing, they are thriving, they are diversifying, they're trying to learn and develop new techniques to improve care. One of the things we think is instructive about this is they're not a big city hospital, they're not a large metropolitan hospital. They are associated with some research centers, but they're a small regional hospital that is trying to get better. And small regional hospitals and health centers can try to implement some of these techniques and technologies to improve how they deliver care. Pinnacle has some innovative people on staff, and they've created this concept they'd like to distribute throughout the organization of the closed loop awareness system. That is, don't do anything that you're not able to measure the outcome of and report back on and understand what you did and how it impacted care. Was it successful or not? They want to do that throughout their organization and throughout all their operations, both care delivery, how they staff, all these various different things. The approach they've adopted to help to accomplish this goal is to say we're going to explain as much variation to the decision makers as possible. I'm going to linger on that for just a second, because that's a very important concept. It differentiates this from a research study. We've all engaged in research studies. They are very formatted. They have a specific protocol that you follow. You are trying to arrive at a very specific understanding of an approach and an outcome and make a conclusion before you can socialize that and say, we now believe that changing this dosage by 10 milligrams per liter will improve an outcome. This is not a research study. This is a form of information delivery. And in delivering information, if you can also deliver to decision makers, whether they be clinicians, whether they be operations people, that, you know what, one of the things that impacts variation in your outcome is this. You can improve or standardize how you approach your way of affecting that outcome. So they want to explain variation, they want to standardize their reaction to that variation, and then measure and see if that results in an improvement of care. Some of the things that they've implemented have been statistical predictions of likely outcomes. I'll show you some examples of survival analysis, which is less dramatic than it sounds, and some time series models to try to give decision makers insight into the outcomes that they're trying to impact and how they can react to them. we'll talk about 2 examples today. I'll try to get this in hopefully 45 minutes or so we can ask some questions. We'll talk about readmissions. I know everyone's interested in readmissions. We were very interested in readmissions when we first got into it. We learned a lot from it. But really as Pinnacle approached this, they were saying, eventually they came to the conclusion, we're not going to try to directly target readmissions and say we're going to reduce readmissions by 30%. Said we're going to see what we can impact, what we can affect to lengthen the time between a patient showing up in the ER or the hospital and the next time they show up. What's the variation around that? Because we can do that, if we can affect it, we can impact it, then we can extend the time between those events. You're likely to impact readmissions. You're likely to have a positive impact on it. You're also going to, if you do it right, improve how you communicate with patients. Let them know where they are. Let them know where they are in the progression of their own disease. Let them know where they are relative to other patients with similar characteristics. So that was one of the examples we'll go through. Another is far more operational, but it gets to care delivery, and that is, how do you make sure there are enough people in a nursing station to take care of the patients who are going to show up? All right? And there is a way of doing that every health system engages in. Everybody has a method of planning what that staffing is going to be. Pinnacle wanted to see if they could use time series forecasting to say, how can we understand what the likely patient volume is going to be on an hour-to-hour and day-to-day basis? Staff in accordance to that. Will we reduce the incidences of overstaffing, understaffing? Will we still allow people to have enough people on hand that will provide a good experience to the patient and will improve patient experience because they have enough people on hand, but they won't have too many? So we'll start with the COPD. And Pinnacle's COPD profile, their readmission profile, very similar to a lot of health systems in the state. Their readmission rate for COPD patients was at 17.8% when we started this in 2012. That's right about the state median, so right about in the middle. We looked back at all of their patients from 2010 to 2013, found out there were 1,800 patients roughly who had a claim submitted for their inpatient visit related to COPD. 327 of those readmitted within 30 days. They didn't, at the time we began this, as of 2013, 2014, have any type of a protocol, a standardized bundled protocol for how COPD patients were treated when they came to the door. They had a lot of good people. They had very well-trained physicians, and everybody tried to do the best they could. They had good care management and transition folks, but they didn't have a standardized way of dealing with a person who came to the door with COPD. I wanted to point out, let me go back to that real quick, if I can. There we go. 1,800 patients to build a statistical model off of is not a lot, okay? So that's going to be something that I think every one of you, if you start to get into this business or get into interested in this, is going to find out is you start to look within a health system and understand the factors of variation within a health system that impact an outcome. Most health systems aren't big enough if you're going to have a tremendous amount of sample size to deal with. So there are some ways to attack that and try to make it actionable. So one of the first things we spoke with regarding the pulmonary physicians at Pinnacle about was what should be a standardized protocol for dealing with a COPD patient to reduce their likelihood of readmission. They had a lot of good ideas. They came up with. They talked amongst themselves and said they had some people who had standard things they did. They compared those lists. They came up with a very good list of practices to help to improve the outcome of the patients when they were discharged and reduce their likelihood of seeing them later. Some of them were not necessarily things that the physician was going to follow up on. Some of them are case management. For example, making sure that there are appointments scheduled within 7 days of discharge so they had somebody to see. They wanted to, if they at all could, discharge people with 30 days of medication in their hands so that they didn't have a problem with being able to say, oh, I couldn't get a prescription filled. They also wanted to schedule paramedicine visits. If they had a particularly high likelihood of readmission, they wanted to be able to say, well, let's actually send somebody to their home at a point in time and be able to check on them to see if it's likely that they were going to be back here anytime soon. Once they put all this protocol together, they came to one very obvious conclusion. This was going to be difficult to do, it was going to be expensive to do, and if they did it for every single patient who walked through the door who they thought maybe was a COPD patient, it was going to cost them a lot of money, and they were not going to be able to justify it to the payers. So, coming through that exercise and going through the protocol, they said, if we were able to justify the implementation of this protocol on a subset of patients, a subpopulation, a minority population, and say these are people we think are at the highest risk of readmission within 30 days, they could probably get the payers to go along with it, and they did. They also said if we could communicate, both particularly to the physicians and also to the patients, why they're in that high risk category, what has placed them there, they'll be able to make better decisions about that protocol, because there might be situations where that protocol, even though it's a very good standardized model protocol, is not appropriate for that particular patient. Because of that paramedicine visit, because of the desire to get somebody on site before the patient came back within 30 days, they wanted some prediction of, well, based on this particular patient, what's the worst case scenario? What is the duration between this hospital admission and the next one that's going to come in? Can you give us a prediction on that? And finally, they wanted some way of communicating to patients, this is the entire population of COPD patients and what we see in the progression of their disease. This is where you are. How can we get you better? How can we move you to a better state? So those are the 4 things we set out to do. The first goal, which was to get some prediction or some identification of a subpopulation of patients who are at a higher likelihood for readmission, we decided to go with a decision tree analysis. Now this is kind of a blunt instrument. It's not everybody's favorite instrument, and I understand that. But when we walked through the various options with the physicians, there were certain things about the decision tree that they liked. They liked the fact that we could limit the number of layers that you went down in the decision, and that you could reduce the amount of variation, number of variables, control the number of variables that are helping you to identify patients in that subpopulation. And they liked the fact that it was sort of a binary solution set, okay? You were either in the group or you weren't in the group. But you could trace back through the decision tree to say, why are some people in a higher likelihood of readmission and some people not? Helps communicate to the patient, the physician, let them make a decision, also communicate to the patient. We're going to go through this in detail in a few more slides. But it was very, very, very important to limit the number of layers of this decision tree. Can't go down. I've seen decision trees with hundreds of variables in them, and they go down, thousands of layers. They might be very accurate, but not very informative. Wanted to keep this at about a 5-layer decision tree and make it informative to the clinicians. When we're developing a model of this type, we follow something called the CRISP-DM process. It stands for the Cross-Industry Standard Process for Data Modeling, or data mining. It's a 6-step process. It is very similar, if you are at all familiar with the scientific method, it's very similar to the scientific method. You set out a set of hypotheses or a set of goals, what you want to try, what is your goal to try to explain variation and understand outcome. You define a modeling process to get there. You have to understand your data and prepare it in order to prepare it for, sometimes it's transformations involved, sometimes it's selecting or aggregating data. And then you build a predictive model, evaluate it, see if you've reached your goals or not. If not, you go back and revise. The key difference in the CRISP-DM process from the scientific method is the concept of deployment. We build these models with proper tools and proper methodologies so that they can be integrated into other technology tool sets. The readmission model, for example, at Pinnacle Health runs every night at 1 p.m. or 1 a.m. Right after they've got the admissions locked down for the day. They run it, they get the results out, it's ready for morning rounds. That is an automated process, and putting that automated process in place takes the right tools and the right architecture, but it can be done. One of the first challenges we face in building any type of a predictive model is understanding the data and understanding what data are relevant and what are not. And sometimes we participate with the clinicians very actively in this process, but honestly, what clinicians see and what they understand frequently is very useful on an individual level. When you're starting to explain variation in a population, it can have its limitations. For example, I used home oxygen as an example. There were lots of things that the physicians brought up to us and said, these are going to be the variables that help to predict readmission. Is a patient on home oxygen? What's their CAT score? What's their pulse ox when they come in? They listed off a whole list of these things. One of the first things we found when we looked at the data is the vast majority of patients who came in the door between 2010 and 2013 at Pinnacle Health were not on home oxygen. And the very few number who were, there really wasn't any type of an indication they were more likely to readmit. So that particular data point, while it's obviously something you want to establish with the patient, you need to know to understand for treatment, from a population standpoint and explaining variation, didn't necessarily explain a lot. There were a lot of variables that did explain a lot. CAT score is a great example. When we had CAT scores on patients, we could make a very good prediction of whether they were likely to readmit or not when they came through the door. We had CAT scores on about 30% of the COPD patients in the population. And that was going to change because they wanted to start getting more CAT scores on more and more COPD patients, but that was going to take time to do. And if you just put that variable into the model by itself, literally having somebody who had a CAT score immediately made them more likely to be a readmission risk, which isn't very informative, isn't very helpful. We did a lot of data dredging like this. What we ultimately ended up with was having a discussion around what's the kind of information we can get on every single patient who walks through the door, every time. And we make very standard observations on them so that we can start to understand the COPD population very thoroughly and comprehensively on something that's measured for everybody who walks through the door. One of the first things we looked at was admission history, because we know their admission history, at least within the Pinnacle Health System. We know how many times they've been in the ER, we know how many times they've been in the hospital. And we were able to do a cluster analysis around the admission records. We looked at a couple of things. We looked to see how many times in the hospital, how many times in the ER, what are your intervals between each. And by doing a cluster analysis around that, we were able to basically take all the patients who have come in for COPD for the last 4 or 5 years and put them into 5 groups. And they sort of advanced exactly the way you'd think. You have people who showed up for the first time they've ever had an exacerbation, first time they've showed up in the hospital, or maybe first time or two. Long intervals, 2+ year intervals in between. Goes all the way, then you start to get the patients who've been in the hospital a few times, 2 to 5 times, 7-month intervals between admissions, etc. It gets more and more frequent, shorter and shorter intervals until you get down to a group of patients in risk category 5 where you have 20 or more exacerbations. They're in every 2 to 4 months. Most of the people in the hospital know these people because they're there all the time. But by identifying them and giving an objective way of categorizing them, we started to put some very objective analysis around categorizing everyone from their admission history. So we know this about every single person who walks through the door, at least based on what they know about their history at Pinnacle Health, and we can put every patient into one of these 5 categories based on their admission history. So we use that as a variable. We used age as a variable, and we used age as a variable to sort of standardize a lot of things about other clinical symptoms that the physicians found useful. So one of the things we talked with them was understanding the interaction between the progression of COPD and its progression through the lungs and ultimately its impact on the heart. And we could see that a lot of patients had one or more cardiac comorbidities that went along with their COPD diagnosis. We also started to look at the function, sort of the mathematical function, between the percent of the population that had one cardiac comorbidity, for example, and that's this blue area here, and what their age was. So at a COPD patient under 50, very few of them, about 20% of the population, has a cardiac comorbidity, one or more. By the time you get up to your 80s and 90s, almost everybody's got at least one cardiac comorbidity to go with their COPD diagnosis. And then we look to say, okay, well, what percentage have two cardiac comorbidities, 3, 4, etc. What we could do is we could use this combination of age and whether they had 1, 2, 3, or 4 cardiac comorbidities to sort of scale patients on this vertical scale. So if you were 50 years old and you came in and you had one cardiac comorbidity, we gave you an index of 20%, roughly 20%. It said you were in the worst 20% of the population. You came in and you were 90 or in your 90s, since you had COPD and only had one cardiac comorbidity, you got a score of 80%. You're actually doing fairly well out of that population. That gave us the ability to take something like that cardiac comorbidity, combine it with age, and provide a continuous variable that we could use within the model to help provide. And the model would go through then and look at breakpoints and say, where are the breakpoints where that variable starts to have influence. We also did it with some very general health information, such as smoking history, BMI, and hypertension. And we were able to look, for example, these are current everyday smokers. What percent of the population are current everyday smokers? Their BMI is fine, they don't have hypertension. That's this blue slope you see here. And you can see that in the 50s and early mid-50s, you have about 40-45% of your COPD population could be categorized as that. By the time you get to your 70s and 80s, not so many. And there's a reason for that. Those people, unfortunately, are no longer with us. But what you do get into the 70s and 80s are a lot of people who were former smokers, some of which you also have BMI problems or hypertension. And this sort of sandcastle or sand art looking graphic also allowed us to provide a continuous variable expression of people's general relative health, give them a general relative health index. Now I talked about the fact that we needed to have information that was available on every single patient. This came in and was generally available for every single patient around 2011. 2010 it was only available for about 20% of the patients. And the reason is, in 2011, meaningful use kicked in, started collecting on everybody. So this is a generally available type of data, but you have to be careful how far back you go, how long you have that information available. And the last thing we were able to look at is everybody who comes in the hospital and is exhibiting certain symptoms gets either a basic metabolic panel or a comprehensive metabolic panel. We spent a lot of time trying to look for breakpoints. You know, what's the breakpoint? What does it say in the literature that an abnormal albumin level is? But ultimately, I started looking at the distributions of the data, and the physicians looked at it with us and said, you know what? You have people who are sort of somewhere in the interquartile range of what you'd expect with these types of measures. And then you have people who are outliers. They're in the outer quartile ranges. Let's just classify as everybody as whether they're in the interquartile or outside the interquartile range. These very basic comprehensive metabolic panel measures. And then we did also take note of people who are on antidepressants and antipsychotics. Now, that's really it. That's all the variables we put into this model. And as I said, if you're familiar with the patient medical records, you know there's hundreds of variables out there. You can throw lots of things in. We tried to keep a relatively simple model to see what kind of insight we could give to the physicians based on this. And we did come up with a decision tree that allowed them to say, okay, patients who are in that risk category 5 for admission history, well, guess what? They're a high likelihood for readmission. Now, that might seem like an obvious conclusion, but having a mechanical process that allows you to identify those type of people objectively right out of the gate, first morning after admission, is a useful piece of information. It's also useful to the physicians because they were able to say, do we really want to spend a lot of time and effort that we are associated with the bundled protocol on the people in this category? These are people frequently who have problems that are best addressed through social services, possibly getting into long-term care or into a nursing home, something to prevent them from coming back here because these are people who show up in the ER all the time. So just being able to break out that group of people was important. Then we started to look into people who showed up slightly more frequently, but not as frequently as risk category 5. The age groupings were very important, and whether they were on the high side of that cardiac comorbidity sign, so these are the people who you generally did not have any cardiac comorbidities or only 1 or 2, versus the people who had more cardiac comorbidities. And some of these people who had more cardiac comorbidities, depending on their general health score and what their outliers were for certain comprehensive metabolic panel results, would show up as higher likelihood of readmission. So the physicians were able to say, okay, I get it. These people are here because they have a cardiac comorbidity. They have a smoking history, or their BMI is high, and they have an outlier in one of these comprehensive metabolic panels. What is it about our bundled protocol we can really look at or emphasize with this patient to help keep them from showing up again? I'm going to go through just a couple more on these. There's actually a few more than this, but these get into the lower risk categories for readmission. These are people who are showing up for the first couple of times. And yes, the cardiac comorbidities were still important. Yes, the general health scores were still important. And yes, the same outliers in comprehensive metabolic panels were contributing to the variation. So same sorts of interactions to get you to the conclusion of whether they were high risk or not for readmission. How effective were we? Well, I talked about the fact that there was not a lot of data to work off of. There are only about 1,800 patients to look at overall, about 300 readmissions. They had to bootstrap these data. That means you have to go back and randomly sample them and basically build up your data set. And you build that up and you get a predictive model that has that's statistically significant and has a fair amount of effectiveness, but you hold out a part of those 1,800 records. We held out about 30% of them, and we tested against that, what we call testing partition. And we found very consistent results between the model that we built and what we tested against. We could identify and flag with those red lights about 40% of the patients. And of those 40% of those patients, they represented just under 60% of the readmissions. So we're looking at a subset of the population. We have better than a coin flip indication that these people are a high likelihood of readmission. That's a justification that Pinnacle could use going to its payers to say, these are people we want to focus on. We want to give our physicians that information. We want to give them the option to use that bundled protocol or not, but these are the people we really want to focus on with that bundled protocol. We took every one of those decision tree populations, every final little branch it came down to, and we looked at every little subpopulation in that branch and said, what is the lower quartile of exacerbation, next exacerbation in each one of those populations? So if the average time back to the hospital was 90 days for a population, we said, okay, what's the lower quartile for that? It's down 30 days, 25 days, something like that. And we said, can we predict what the worst case scenario is from that as to when the next time they'll be back in the hospital? We got a very nice 85% R-squared regression between subpopulation and the lower quartile. It makes sense. The decision trees segregating variation like that. We were able to give this information along with the red light to the physician on the first morning after admission. So here's this is a person, they belong in a high-risk population. Based on that, their worst case scenario for showing back up in the hospital is 25 days. As you're implementing the bundled protocol, if you think it makes sense to schedule that paramedicine visit, schedule it within 25 days, because otherwise that's our worst case scenario if we're thinking that they're going to be back in the hospital. So we were able to give them that analysis. The last thing we were able to do is go into what we call a hazard analysis. And I classify this under things I've learned from engineers, because this is an engineering concept. Anytime you build a mechanical device, you want to use it over and over and over again until it fails, and say, okay, well, this thing will work for 2,000 uses, and then it will finally fail. What everybody really wanted out of this was to be able to take all the COPD patients and look at them from diagnosis to death, and say, what's the relationship between the years when you were diagnosed and how likely you were to expire in the first year versus 10 years out and your likelihood of expiring. We found that getting data on when patients die is not easy. It's very difficult. You have to go to the Social Security Index and pull things out of there. It can be done, but within the confines of this particular project, Pinnacle didn't want to go there. So we were able to say, okay, well, we do know two things about these patients: when they were diagnosed with COPD, and if they had a first readmission. So we were able to do a hazard analysis, and there's a methodology for this. It's called a Weibull analysis. You make sure there's a statistically significant linear trend between the time since diagnosis and the probability that you're going to face a readmission. And it could go up or it could go down. But what we found is that for all age groups, we sort of divvied up the patient population here into 3 age groups. And we did this based off of quartiles. So the lower quartile range of patients were 69 and less. Patients between 69 and 77 were the interquartile range, and then patients over 77 were your upper quartile range in terms of age at diagnosis. And we said, okay, well, of all these patients, what is their likelihood of readmission in the first year after diagnosis, second year, third, fourth, fifth? And we saw that it went down for all 3 populations. Now, made sense when we looked at the data for, again, the people who were diagnosed at 77 or over. One of the reasons they have a very low likelihood of having a readmission event 5 years after diagnosis is they have a very high mortality rate. So they don't often get to 5 years since past diagnosis. But the other groups do. The other groups' mortality rates are not nearly as high in the first 5 years. And they still have a declining trend in the likelihood of having a readmission event. Much steeper for the group in the 69 to 77 year range. That's the green line here. A much shallower curve for the patients in the lower than 69 age range. The lesson coming out of this, when we looked at this and we reviewed it with the physicians, was patients who are diagnosed with COPD go through a lot of life changes. They have to learn to manage their condition with medication, with home oxygen, a variety of other things. Sometimes that's effective, sometimes it isn't. If you can keep a patient from coming to the hospital and having to come back again early after their first diagnosis, and you can get them through the first couple of years, you can significantly reduce the likelihood that they're going to be coming back to the hospital for a readmission event, a 30-day readmission event, in their 4th and 5th years. So one of the things that the physicians use this to communicate to the patients with is, look, you're in your first year after diagnosis. You're at the highest risk of readmission. We really want you to concentrate on these things. We're going to set up follow-up visits. We're going to send you home with prescription medications. We're going to get you pulmonary consults and cardiac consults and all the things you need to know about so that you can really actively engage with your clinicians and try to head off the likelihood of a readmission event. And then if we get you to the point where you're 3 or 4 years after your diagnosis and you understand how to live with your condition, we will possibly back off on that protocol if you show up again for exacerbation. We know you know how to live with your condition, and we'll treat you for what you're coming in at that particular time. So we did all this work, and it was really great, and we went to put it into place, and we spent 2 months trying to identify how you find a patient the first morning after admission who is a COPD patient. And you'd think it'd be simple. You'd say, okay, well, go back and look at history. Do they have COPD on their DRGs? Well, sometimes the physicians didn't like that because they said, we don't want to go with a past diagnosis. We want to go with our own diagnosis. We dug through a lot of different things. We eventually came to a set of data. We did a lot of data dredging and working with them to say, well, anybody who comes in and gets either albuterol or Duonev and a steroid, somebody's really concerned that they have COPD. Whether they're diagnosed with it or not, somebody's really concerned that they have COPD. So that became the standard that we use. So anybody who comes in the door with those two criteria, before midnight, and they get identified with that, 1 o'clock in the morning, the model picks them up, calculates their likelihood as a readmission risk, calculates and puts them in the scales of the other models we talked about, the likelihood of next exacerbation and where they are in the population, and produces those results for the next morning's rounds. And the physician, when they're preparing the care plan for that patient, can communicate with them and say all these various things. They can say, okay, are you at a high risk of readmission? Why is that? Is it because of your exacerbation history, age, and cardiac comorbidity interacting? If so, we want to implement the protocol. We want to get these various things started. Is it just because you are in that high risk category for exacerbation? If so, maybe we want to set up a social services consult. Maybe we want to talk about getting you into a nursing home or long-term care instead. If it is the former, if it's just somebody who's a high likelihood of readmission, it's because their clinical characteristics indicate so. What's their next worst case for exacerbation? Let's make sure we schedule follow-up with your primary care and a paramedicine visit before that date so that we can assess you and see if we can keep you out of the hospital. And then let's have your physician talk to you and say, how old are you? How many years has it been since you've been diagnosed? How are you learning to live with your condition? What can we do to see if we can get you to that point where you're comfortable living your condition, and on a population basis, you're less likely to show up back in the hospital. So all of these things are wonderful, and they've been put in place. This was originally put into place August of 2014 in one pulmonary unit at PinnacleHealth. It was evaluated for a period of about 6 months, and the biggest struggle they had was getting everybody trained on the protocol and getting that standardized. They found it to be effective. They decided to implement it hospital-wise. It took them a year to train all of their pulmonary units on the standardized protocol, how they were going to put it into place. And last month, they rolled it out to all of their pulmonary units. So we finally got it out there. Now, one of the things that comes from being a contractor rather than a research collaborator is I have to ask for performance results, and sometimes those get shared, sometimes they don't, because Pinnacle is monitoring this on their own. So I honestly don't know how effective it has been for them. I do know it's effective enough that they put it into all their pulmonary units. But it did face a great deal of struggle in trying to get to the point where putting that protocol into effect was something they could do on a regular basis. Okay, I'm going to go into a second example for a couple of minutes and talk about staffing. We talked about this a little earlier. Pinnacle was very interested in saying we'd like to staff to, they want to minimize the variation in the patient-to-staff ratio. They frequently found that sometimes they had way too many people on the floor, sometimes they had far too few. They wanted to get within one deviation of the mean if they could. They expected this to improve the patient experience, improve staff morale, minimize the need for overtime. This is a very busy graphic, and I frequently make a point of telling people that my informatics developers did not develop this. But the more I stare at it, the more I realize how useful it can be from an informational standpoint for planning operations. So let's start with all the information that's on here. The blue line at the top is the number of patients who showed up in a particular nursing station over a 24-hour period. You can see it's relatively level. The gray lines in the background, the gray bars, very light gray bars you're seeing bouncing up and down, that is the number of staff who are present in that nursing station. And what the little arrows, either green arrows or red arrows pointing up or down, are representing is the patient to staff ratio. And there are times when the number of patients is much higher than the number of staff. That's represented by these red arrows here. There are times when the number of patients is the ratio is much lower, that patient-to-staff ratio. That's kind of inefficient. There's times when it's right on the mark. And there's times when it's right on the mark, and the reason is because of these little copper tops to the bars. That represents staff overtime. So yes, they're able to maintain a nice patient-to-staff ratio in this area to the left. The reason for that is they asked people to stay and do overtime so that they had enough people on the floor. So the whole purpose of this exercise was, if we knew, if Pinnacle knew, that this was going to be the patient volume on that floor on a daily basis, they could theoretically say, here's how many staff we need to deal with that many patients hour by hour. Now, every organization goes through a predictive process for staffing. It does not necessarily mean it's done statistically. It could be done because there are union contracts. It could be done because people know in general on Thursdays we have a ton of people show up, things like that. So it's based off of experience, it's based off of legal maneuvering and obligations. But for some way or another, somebody makes a decision, this is how many people we need on the floor. What we're trying to do is say, if we can give you a little bit more insight as to how many patients are going to be on the floor, maybe you could adjust that. We did not have a tremendous number of variables to work with. We did have very good data, I will say that. Pinnacle had gone back, they'd gone through all of their patient volume data as well as their staff data on an hourly basis. They're able to say, this is how many patients were on the floor in each nursing station for each hour, all the way back for about 11 years. It's great. They're also able to tell us this is how many beds are available in each nursing station, because if you build forecasts, they don't care how many beds are available. They're going to say you could have 5,000 patients in that nursing station if that's what the indication tells you. You had to put some sort of upper limit to say, oh, hey, you've reached your limit, there's 40 beds, you filled them all, you're at the end. Our approach to this was use time series analysis, and we had to do a little bit of manipulation here to make it work. We had to first predict sort of that daily rise and fall of patients. You know, you don't see as many on the weekends, you see a lot more during the week, that sort of thing, as well as weekly and monthly variation. And then we were able to use that prediction of what the daily volume was likely to be as an input into an ARIMA model to predict hourly variation, because that's much better at picking up short-term trends and accounting for them, especially if you put some seasonal variation, seasonal factors in there as well. One of the things I learned about this, I had used time series always to identify whether populations were going up or populations were going down, and teasing out the seasonal variation in that way. You don't want to go very far back when you're looking at data to pick up a trend. Sometimes we only went back 14 days, sometimes we went back 30 days. You went back too far, it started to pick up very general trends and make a very general prediction. And that wasn't particularly useful to them. We only had to look back a couple of weeks in some cost centers, and in back 30 days, I think is the maximum we set for a lot of nursing stations, to help predict, see what the trend had been, and predict what we thought it was going to be. These models are set to run and update every single day. So they're always looking back the last 14 days, the last 30 days, pick up the variation and tell you what they think the next forecast is. And this is an example of how it worked. This is the Cardio-Thoracic unit, and the gray bars again are the number of staff who are actually on the floor, staff hours on the floor. Nobody was using this information at this time. They were still staffing the way they always had. The purple line here are the number of patients who actually were in the unit on each particular day. This is a daily trend. And the blue line is our prediction. This is a prediction, since this is an actual range, this is the prediction that was made 3 days out for this area. And then this is the future, so here's what we think it's going to be for the next 14 days or so. And what we were able to glean from this, we used this as our initial evaluation. We wanted to be able to, in the actual range, be able to say, okay, on 80% of the days, we want to be within 80% of the patients in our predictions. If we could do that, we'd say that, okay, we've got a good model for this particular nursing station. Out of 42 nursing stations, we were able to do that with 35 of them. We were never going to do it with nurseries, because you can't predict babies, ever. We were never going to do it with very low volume nursing stations. We had a lot of nursing stations that maybe see 10 patients a day, so it's very hard to do a prediction on that. But with about 35 out of the 42, we were able to get a prediction that met that criteria. So then we were able to change this graphic a little bit to help them improve staffing decisions. We're still looking at actuals over here. The gray bars is the actual people who were staffed at this nursing station. This is the ED here for one of the hospitals. The purple line again is the actual number of patients who showed up. The blue line is the prediction. It's tracking fairly well, and it's telling you what the prediction is going to be, in this case, for the next 7 days. 8 days. The sort of beige bars out here to the right, those are the staff who are projected, scheduled to show up in the ED for the next 8 days. And by looking at the dots, looking at the little arrows, you can see there are 2 days when they're likely to be short-staffed. The other 6, it looks like they're okay. Now they can click into these arrows and actually see on an hourly basis where the problems might be. And this is, actually they did some clicking in the past and realized that around about somewhere between 5 and 8 a.m., there's a shift change. And sometimes that shift change means people leave early, sometimes it means people come early, and sometimes it means you're overstaffed, sometimes it means you're understaffed when that shift change was going on. So in looking at some of the projections out into the future, they were able to say, if we can schedule folks so that that shift change has minimal impact on the number of people who show up, and we can likely predict where the patient volume is going to be, we can minimize the number of times we're going to be overstaffed or understaffed in that particular ED. So they've been using this to try to level out those staffing decisions on a nurse station by nurse station basis. And like I said, from some ways when I look at this particular graphic, I think, wow, there's a lot of information on there. It's almost too much for me to make a decision. But the people who are actually looking at this and interacting with it appreciate having that much information, appreciate being able to adjust their staffing decisions where they can on that basis. Pinnacle has a little slogan, which is they say, we define analytics as prediction. We want to make a prediction and operate to it in order to see if we can level out variation. We want to explain that variation, standardize our approach to it, and see if we can affect it. And that's what we've been trying to help them to do. So they've made a commitment to the technology and the people and the staff and the implementation to do that. And we're helping them work that way, and I think they're making good progress. But that's a lot of what we've learned in the last 3 years working with them, in terms of, we've got to prepare for there not to be a ton of data, got to prepare for there to be a need to build models that maybe aren't the perfect model, but are informative and explain variation and allow you to communicate with the physician, and then do as much as you can to explain variation in other operational areas as well, so that people can make better, more informed decisions and standardize how they're running the operation in general. Okay, thank you. So we have probably about 10 minutes for questions if folks have questions.